you see it? Let's see. Can you?
Yes.
Yes. Is it clear?
Yes, it's clear.
Okay. So I've been asked to talk about data, outcomes, diabetes, and how do they intermingle with each other. So let's start off. Data is and outcomes comes in three parts. One is for the individual, the patient themselves. One is for the clinician, that is ourselves, and then is for the system. When you're looking at, so for example, when you lead an organization and things like that. So let's look at it from different ways gradually as we go along. So to begin with, let's look at the person, the individual. So for me, data is a lot about self-management. So whether you talk about modern technology, which again is linked with how much you can afford and what you can buy, whether it's flash glucose monitoring and Libra and CG, and not a lot of people can afford it, which is why there's a problem as to how much people can self-manage, because there's only so much data you can get by finger pricking, etc. The other thing, the outcomes that matter to people, there's some really good studies where if you go and ask people with diabetes what matters to them most, we as doctors always say heart attacks and strokes, but to a lot of people with diabetes, the top few things that they talk about is, I don't want to lose my leg, I don't want to go blind. For women, it's pregnancy, being safe. So there's a bit of a difference between what we as a doctor would like to tackle, what the individual would like to tackle. So that's quite interesting when you look at some of the papers and what means data, what is outcomes to people. To the clinician in the UK, we got this data integrator. It's called DIASEN. So all the glucose levels or all whatever meters you use or flash glucose, they come into one place. So we have the opportunity in clinic of looking at all the data. And whichever data stream you use, it is important that as a clinician, if you're sitting in clinic and you look at trends and you look at numbers, you can at least have some. So for us, that is quite important. So it becomes, okay, without the data, we can't really work in clinic, because the only data otherwise we have is just an HbA1c. And with HbA1c has been, traditionally, it's been a very good marker for control trials, etc., how we work. The problem is, does it help the individual? Is it and the outcomes? So for you as the clinician, the bigger question is, what makes the outcomes are something that I feel that you go home and feel very proud of what you've done as a diabetologist. Is it the individual patient feedback? Dr. Saab, you were amazing, and you've changed my life. Is that the most important outcome for you? Is it the fact that you've dropped people's HbA1c and you consistently can do that and you feel quite proud of your skills as a diabetes doctor? Or is it about, if you're in a clinic and say people said, okay, you looked at 10 people and look, those 10 people compared to, let's say, other places have had less heart attacks, amputations. So it depends as an individual, what to you is seen as an important thing. So that's quite interesting as to how people see what is important to them, the individual patient, the individual clinician. Then you look at a system, and when you look at a system, it becomes much more wider. Now, here is what I wanted to talk about, and I was quite interested, and we'll talk about it in the end, because we'll talk a little bit about the UK system, which is very fundamentally different. Let's make no two bones about it. People should stop comparing a UK with an India. I mean, listen, the whole population of the UK is less than just the population of West Bengal. So let's not even get into comparisons there. But there are some things which can be done. So for the system, the question is, do you need to have system-wide data sets? How do you change your diabetes patients? Because as a diabetologist, you want to see them earlier, not later. The frustration we as clinicians have a lot is people turning up to see you being referred on much later, when you got less chance of making impact on their outcomes, so to speak. So one of the things is we need to have data on every single aspect possible, because without data, you have no argument to have. So for example, even in an Indian setting, if you're going to lobby, let's say, the government for extra funding or whatever for X, Y, Z, you can't have one because you don't have the data to show to the politicians who matter. But to the politicians, along with diabetes, they have to have so many disease processes to look at. But if you then say to them, look, here is the issue, here is what is costing you as a government to pay for everything, but if you did invest it front up, you would have a benefit. But it is important to review that progress, and you have to have pride in a success. And sometimes it won't work. You have to have acceptance of failure. For example, if you're saying that amputation rates are going up, then it is not a failure of the individual. It can be the failure of the system. Poorer people having worse outcomes, that's not something clinicians can impact on. But that's the data system you can have as a whole area and have a conversation with the policymakers to say, what can you do? Because those people are actually costing you much more because of the risks of complications. And in the NHS, for example, if you take 100 pounds, 15 pounds is spent on treatment. £85 or 85% of the total budget is spent on complications. So the important bit that we are trying to move towards is, okay, we need to invest much down the stream. Like we talk about prevention, talking about early use of drugs, whether it's insulin or the newer drugs, SGLT2 and GLP-1s and all that earlier. That's where you invest, so you can cut down on the total budgets you're having in the complications. That's what data does for you. You can have those arguments. So if you look at these, here are some examples, how data streams matter. So here is something on the extreme end. You've seen the Libra readings, then you got the Dexcom readings, and I've given you some examples of clinicians, what you see. So we in the UK will have these, the bottom one is the Dexcom one, which is called Clarity, and the above one is called Libra View. So we sit down and we can have a look at that in clinic, and you can see as an individual, patients, before they even come into clinic, whether it's physically or virtually, you can have a look and go like, okay, these are the bits we can sort of target, these are the bits we can talk about, and let's see what we can do. Are they having hypos? Are they not, etc. So for the individual or the patient, you can see, let's take the example of the Dexcom one, you can see that individual going, okay, well, this is my number, this is my HbA1c, this is the time I'm actually dipping into a low reading. What do I do need to prevent it? Well, for the clinician, you can have exactly the same approach of trying to sort of help them with it. So that's quite an interesting and different approach to how we do diabetes care. And that's where data is so important. So I just want to spend some time about what we have in the UK. Again, please do take it with the purpose it is, which is this is not a comparison. We are a very different funded health system. We've got budgets, we got public funded health system, we got high, as far, and correct me if I'm wrong, the GDP investment into health in India is about 1 or 2%. In the UK, we're talking about 9 or 10%. Huge difference, massive gap. So we can't sort of have that comparison. But because we have the data and stuff, so what we do have now, we have these national audits, but it drills down into each hospital and each GP surgery, however small they are. So what we do have, we have got pregnancy audits, and because of the pregnancy audits, we have done the continuous glucose monitoring bit into type 1 diabetes pregnancy. We've got foot audits. We can see what's happening to amputations over the last 5-10 years. We can see what's been happening during the pandemic. Has it gone up? Which area has gone up? Which area has gone down? What's happening? Are we missing out? Have amputations gone down because a lot of the people are not mobilizing? A lot of people with higher risk of dying? Or is it going up because care has fallen off? Inpatient audits, that's been a very, very fundamental thing about getting funding. For example, we keep on showing the safety is a big issue. And those of us who are diabetologists know this. You go into an orthopedic ward, people don't know what diabetes is. So you as a specialist get called in too late. And by the time you turn up, the blood sugars are really sky high, or somebody's forgot the insulin. Now, what we have done because of those audits, we now have specialist teams in each hospital. We have been able to invest into that to show to the government, look, this is a safety issue, which is actually costing you more money because you have a harm, you have an error, or because of their diabetes, they stay in longer. Or if you want to help your surgical colleagues because they want their beds quicker, well, with the help of a specialist team, we can get them out quicker, that sort of stuff. We have recently done a young type 2 diabetes audit. So how many people who are below the age of 40, from the age of 0, have got type 2 diabetes? So we always have thought about type 2 diabetes as a disease process of the middle-aged. Now what we are seeing is a very fundamental shift. We got 10,000 people in the UK below the age of 18 right now who have got type 2 diabetes, which shows the environment in which we're working. What do we need to do? We're talking to the government about changing the strategies about, what adverts do you have on TV? What sort of things, when kids are watching, are we sort of saying to celebrities not to do adverts showing, here is your big cornflakes with chocolate, Cocoa Pops, etc. So it's about that cultural change as we're going along. Type 1 diabetes audit has been big. Again, same principle. What is happening in hospitals, which is talk about and mention about the getting it right first time. The simple principle is we go around to hospitals and we benchmark it. So it's not a league table. It's not about shaming the people. What you're saying is that this is where you sit as regards the mean or the median of the country. Now, this is what your area is doing. This is not about saying you are 27th in the country. We don't do lists like that. What we say is that this is the mean or median of the country as regards, let's say, hospital admissions with or readmissions with people with type 1 diabetes goes. So type 1 diabetes, they come back with DKA sometimes. So we look at the mean or median of the country and then we say to hospitals, okay, you are doing better. Please tell us what you're doing so we can tell the rest of the world. Or if you're not doing so well, what can we do to help you? What other areas do you want to learn from? So those are, again, quite important. So this is what we have, which is publicly available. You can all go onto it and have a look. So we got this national diabetes audit, as you can see, very recently published, and its data till the 31st of March. As of this country, as is happening, all the blood tests done. And you can see every single area in the country, we have this data. As I said, it drills into hospitals, drills into GP surgeries. It is the most comprehensive data set in the world as far as diabetes. No country, apart from I think Sweden, will be able to compare with this data set. And we have put a lot of time and effort into doing this. We have got automatic data draw systems, etc., IT systems to do this. Without it, you can't change outcomes. That is an important message. So here is something that we have. So if you can see, we've got care process that every patient with type 1 diabetes and type 2 diabetes should have X, Y, and Z done. So look at this in type 1 diabetes. Are they having their HbA1c checked? Everybody. We're talking about everybody. This is no gaps. Are they having their blood pressure done? How many people? How many people are? What are we missing out on? So you can see areas which are really low. And immediately you see from this slide, what you can see is the ACR checks in this country is very low. So we are not focusing on, so for us, it's about saying to our GP colleagues or hospital colleagues, guys, you're doing really well in the checking of the HbA1c and the blood pressure, but you're not checking ACRs, which are very important for renal examinations, renal. So that then becomes a focused area as a national team. So I do the national role. For me, then it becomes, okay, do I need to invest something to get those levels up? Because we are saying 50% of people in this country with type 1 diabetes are not having the ACR checked, which is not right. So what we do is we put the money into that side of things, do the education, do the focus, and the idea would be to change that. So type 1, again, you can see this is, I'm not going to go into the details. CCG basically means smaller areas of the country, like little geographical areas. And we can see, you can see from the scatter plot, what we are saying is that how many areas are managing to get their HbA1c less than 58 or 7.5%, which is what we're trying to go to. You can see the variation across the board. Some doing really well, some huge outliers, right? Some doing much better than outside the confidence limits. So what you get here is the ability to go and then talk to the region and say, look, guys, you are so far outside the normal range. You're not in the pack. What can we do to help? What's going on? Where do we go? So that's an important point of the data. So we got all this, and then I talked about, this is also published, which I've been part of. We went around every hospital. And I'll show you the importance of this data stream that we've got. Have a look at this. This is about diabetes ketoacidosis admissions based on age around the country. What do we see? We all know this, but this is crystallizing data. What we now know is you can see from the age of 17, 18 upwards, you can see this huge spike in DKA, right? We know that young people are more prone to getting into DKA, but rather than just saying, well, they're just young people and, they go out and party and drink and whatever, what we want to do is put investment into that. We want to have dedicated teams. We want to have social care workers. We want to have more education, pubs and nightclubs, etc., because we want to bring that rate down. Without that data, we can't focus into that age group. So guess what? The policy for next year that we are changing or we are implementing is to say, we need specific teams looking into age groups 15 to 25. There is a rise in DKA admissions, which we need to tackle. So that's the approach towards data. And here is the final slide I will show you before we talk a little bit more about, what does it achieve and all that. Here is a data scatter plot you can see where we're talking about people who are on pumps. So we talk about insulin pumps, and you will hear from my fantastic friend Pratik next. He will talk a lot. He's one of the absolute legends of technology in the work that he's doing, etc. But have a look at this. This is places all around the country doing insulin pumps. And look at this plot. There are hospitals in this country where everything is funded. Don't forget, they're all funded. People don't have to pay. Where 0% of their population are on pumps. Zero. There are also places where 40% of their population are on pumps. So you can see the divide, huge gaps. What we are now doing is, and we have gone to all those three centers to say, what is going on, guys? Is it about education? Is it about support? So to help with the education, Pratik has led on this, and we have worked with them to create this education portal. We have got a national education on pumps, free for every healthcare professional in this country. You can log in, you're free, you sit down, you learn about pumps. Because the idea is, what we're saying is that if you are not being able to give access to people to pumps, even if it's funded, there must be something that you're not aware of. So that's what we are tackling. So that is only possible, that sort of investment of focus planning, once you know what is going on. So that is important for us. So what we do is, what does it achieve? It gives you focused data during pandemic. We were one of the first countries where we said everybody with diabetes, based on your age, obviously, should get a priority over the vaccine. Why? Because we produced national data sets during the pandemic to show that people with diabetes were dying more. So we straight away were saying, right, diabetes patients need to be prioritized for vaccines, and we managed to do that. We managed to do an overview of all the medications, because there was a lot of talk about, oh, is SGLT2 inhibitors harmful? Is GLP? So we did all the data sets. And what we found is that they're all pretty much the same. Nothing. There's no need to stop any medications because they may get COVID. So no need for that. We are also looking at what processes have dropped off. As you would expect, during the pandemic, lots of people haven't been able to see their doctors and their nurses. So we're trying to find that out. And also important points about, what do we get with amputations? What's happening with diabetic ketoacidosis during the pandemic? So we got all those data. So interesting fact, and it's been published now in the Lancet, is that you got diabetic ketoacidosis admissions have actually gone down in this age group. And there's a lot of social lessons there to learn. For example, colleges were shut, universities were shut, nightclubs were shut. So all the people and all those trigger factors, people are with their parents at home food, etc. Guess what? Diabetic ketoacidosis admissions in that age group has fallen in type 1 diabetes. So lots of things there to learn as well, and what we can do to support. And final few things to say, what does it achieve is that sort of data gives us, as I said, because we have to speak with politicians on a regular basis about money, gives us continued investment into diabetes. It gives us improvement in all possible markers. Over the last 5 years, and this is something we are very proud of, our amputation rates in the UK have gone down. Our emergency admissions in the UK have gone down. Cardiovascular events have gone down. People with diabetes, cardiovascular deaths are no longer the most important reason of their death. It's no longer the number one reason. It's cancer, because you have to die of something. But CV events are no longer number one. What else has happened? Mortality with people with diabetes has gone down. So you can't have hoped for a better outcome. And all this is possible because we have these data sets, focus, investment, and a lot of national changes we can do. So for me, without data, there are no outcomes. How do you know you're doing well? Without data, you cannot improve diabetes care. Is it possible in India? Is it too big, or is this possible in small networks? So to me, I think RSSDI, because of the work they're doing in type 1 diabetes, is fantastic. You can lead the change. You can do it in smaller areas. You can do it in states. You can do a lot of the good work that is already existing. And I know some areas are already doing it, but I don't think it's impossible, because without data, you will not be able, you might be able to do it individually in your clinical work because you're an excellent clinician, but as a system to do it, or to convince the politicians and industry and others to invest in it, you need the data. Without the data, you can't do. Data is king. Data is very, very much important. So last slide before I take any questions on this, you can't improve what you don't measure. Anecdotal evidence is worth nothing. People can talk about whatever they want. At the end of the day, we are all scientists, and this is how we do science. You look at data, you convince yourself that's the right thing, and then you move on to the next phase. Without the data, they're all impossible. So I'll finish there, and I will take any questions you want.